Thank you. It's really an honor and a privilege to be with you this morning. It's an honor to be sharing the podium with such smart folks and less clumsy folks. Full disclosure, I am still on the Blue Cross Blue Shield of Texas payroll through the end of this week, and I join the Heart Association next week. I sent information out to folks and got some responses back. I'm going to share a couple with you because they're kind of funny to break the ice, at least my ice. Regan Minners, who's with the American Diabetes Association, sent me a congratulatory note with the subject line, "Hearty congratulations, H-E-A-R-T-Y." Some of y'all know, probably most of y'all know, Doug Scutchfield at University of Kentucky. Scutch sent me an email that said, "Back from the dark side of the force, I see. Welcome home." Not sure that I concur with the notion of being from the dark side, but I am glad to be home. Harvey mentioned a small but hearty band, and as I think about the notion of the health dividend, as Dr. Teutsch pointed out, perhaps we need to take a Robin Hood strategy and take from the rich medical care system and give to the under-resourced public health, human services, social services, healthy built environment systems. I prepared some comments that are in response to some questions that I was asked to answer. And I'll try to get to the answers quick now and then go through a little bit of discussion and build up to why those are the answers. As Commissioner of Health in Texas, I learned that when testifying to the legislature, start with your conclusion and then make the case, because you may never ever get to the conclusion part as you're talking to folks. I did put up there a framework on population health, and this is an adaptation from something. I'm going to need y'all to advance the clicker and just until it's completely there. And it's just a way to think about the charge of this IOM committee and perhaps one framework. And I've seen others and others of your slides offer different frameworks. 3 questions I was asked to answer. What are the critical opportunities to improve population health? I think quite simply, investing the health dividend, and if indeed there's $765 billion of waste to be extracted from the system, how do we invest that in health? And I'll talk a little bit about that. What are the obstacles to health in all policies and other intersectoral approaches, and how can they be transcended? I think there's at least 3, and I'm going to talk about those. 1 philosophical, 1 definitional, and 1, the big one, is political. And then 3, practically speaking, how can we make a business case for population health? And I'll try to do that in the course of my comments. Again, I think that the best opportunity to improve population health is the absolute necessity that we have to improve the public's health as a strategy to bend the cost curve. Improved health status should reduce the demand for expensive medical care and therefore reduce expenditures. And the growing appreciation of the relationship between the health of the workforce and productivity by employers, and the growing appreciation of the relationship between the health of the workforce and economic competitiveness by chambers of commerce are other opportunities that we have not only to make the case, but to engage the business community, start the conversation. However, I think that a lack of consensus on a societal value for health and a lack of consensus on what population health is pose some challenges. In the health plan world, and I'm wearing lots of different hats, but I'm one person, and so this is a perspective of many perspectives out of one brain, and I hope it's not a reflection of multiple personality disorder, but simply a reflection of having had a number of different experiences and thought about this over the longitudinal time of those experiences. In the health plan world, population health is associated with medical homes, accountable care organizations, disease management, and wellness. Perhaps some other things, but that's sort of the frame. And perhaps the phrase closing gaps of care best encapsulates the notion of population health from the health plan perspective and the value that health plans believe they bring to achieve gap closure. and that would be in the realm of disease management, case management, and preventive services. But in my view, that is a narrow, though often used concept of population health. Shorter lives, poorer health. The recent IOM report points out a big gap that needs to be closed. As we've heard already, as everybody already knows, we spend more on medical care than every other comparable country, and yet we have poor health status in general. So really, two gaps, a health status gap and a health care expenditures gap. Too often, it seems to me we are asking incomplete or possibly incorrect questions. The questions are sometimes framed this way in the settings that I've been in having conversations. Is it that we don't do medical care well enough? Perhaps. Is it that we are insufficiently or inefficiently doing medical care? Perhaps. But the fact that medical care is part of that question says we are very narrowly focused on what the solutions are. We've come to believe that bending the cost curve, extracting the $765 billion of waste out of the system, will happen by doing medical care better. Less duplication, more prevention, less administrative burden, reducing salaries, and the list goes on and on. However, it's difficult for me, and I suspect for many of you in this room, to believe that our medical care re-engineering efforts can outpace the growing burden of chronic disease. Diabetes and dementia are but two that come to mind. Diabetes, because I've spent a lot of time thinking about it, and dementia because it's been in the news very, very recently, and the projections suggest it's going to be a bit of a challenge for us to manage that. We have to look at health promotion and disease prevention, and when I use those words, I mean them very, very broadly. Everywhere it can be accomplished with a population health focus to slow down the onset of chronic diseases. You know the literature. Fitness at 50 equals delayed onset of chronic disease in your 70s and into your 80s. Fitness at 50 equals compression of the morbidity curve. Those indeed, to me, are strategies that we might, well, those are indeed are goals, that is fitness at 50, to pursue that might indeed reduce the burden of reduce the demand for care among Medicare age individuals. And then the Diabetes Prevention Project, I think, provides the evidence base for intense lifestyle intervention in community settings to significantly delay the progression of prediabetes to diabetes. The American Heart Association's Life Simple 7, and I've been talking about this before I joined the American Heart Association, so don't think I'm doing this just because. I think provides a construct for improving and actually measuring population health. The Simple 7 are avoiding tobacco use, eating healthy, being physically active, maintaining healthy weight, blood pressure, blood glucose, and lipid levels. You may have seen a study in JAMA last year that showed an inverse relationship between the 7 elements and relative mortality. In other words, if individuals with those 7 characteristics had a lower mortality rate than individuals with none and or less, and it's a stepwise relationship. Different studies showed an inverse relationship between the 7 elements and incidences of 4 kinds of cancer: lung, colorectal, prostate, and breast. 3 of the Simple 7 are the 3 key components of the lifestyle intervention to reduce the progression of prediabetes to diabetes. And when one begins to consider the options to make less tobacco use, healthier eating, and more active living the norms, the opportunities and the necessity to think in terms of built environment for health, school and worksite policy for health, and health in all policies become self-evident. But maybe that self-evident notion is one that's only shared in this room. We are the believers, and part of our task is to begin to engage those who maybe don't see the world the way we do and try to make the case for why they should. The Simple 7 are the wash your hands of chronic disease. What are the sinks and clean water to improve population health? They may include parks, grocery stores, safe and walkable neighborhoods, children's health programs, health in all policies. I will say Blue Cross Blue Shield of Texas and Healthcare Service Corporation and other health plans are engaged in some charitable contributions and some programs that are about improving population health. but I would say that those are somewhat ad hoc and not necessarily informed by consideration of a broader framework like the one that I've got showing on the slide. I want to mention blue zones as well, add to what Kathy Bossi had to say. There are 9 characteristics that have been described by the blue zones spokesperson, Dan Buettner. Some of them have to do with lifestyle behavior. Some are related to social connections and relationships. Healthways now has a partnership with Blue Zones. Healthways is the organization that's doing the Gallup Wellness Wellbeing Index. So there may be some opportunities to tie some things together. There are some challenges, though. One of those challenges is definitional. What is public health? I got a list here of some things that maybe are public health, and I will suggest to you they're every single one of these, and yet they're not all the same. The health status and ranking of a state, health status and ranking of a city or county, the services and programs offered by a health plan that complement traditional clinical care services, the results of wellness programs and health insurance benefits offered by an employer, the efforts to reduce hospital-acquired infections and readmissions by hospital system. Are they among the objectives of accountable care organizations or the patient-centered medical home, or now called sometimes health home? Are they the array of programs and services to optimize diabetes outcomes in medical care practice? And is population health merely a euphemism for public health? I say that as a public health officer in Texas. My last 2 years, I was told over and over by people who were trying to advise me not to use the words public health. Kindig and Stoddard, Jacobson and Teutsch and others have offered definitions widely cited in the literature. They are definitions that, in general, speak to the health of total populations and not the subpopulations that I enumerated. Perhaps borrowing from the World Health Organization, population health should be defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity for an entire population. And this definition might be thought of as the desired state, the destination, to repeat what Kathy said. But for many, population health is a discipline, an area of study, or a function or set of functions. The Patient Protection and Affordable Care Act has established universal access to health insurance and medical care in the United States as a new norm. But perhaps we should aspire to a loftier standard, universal equal access to health, and to a loftier goal, optimized total population health. Because I think all of us would agree in this room that while universal access to health is a moral imperative, that it is a good thing we have at least debated and taken a step towards universalizing, it is necessary but not sufficient to achieve total population health. After all, the Declaration of Independence states that we are each endowed with certain unalienable rights, including life, liberty, and the pursuit of happiness, and it doesn't seem like much of a stretch to me anyway to suggest that a state of complete physical, mental, and social well-being is kind of contained in the notion of liberty, life, liberty, and the pursuit of happiness. Article 25 of the 1948 Universal Declaration of Human Rights states that everyone has the right to a standard of living adequate for their health and well-being. Furthermore, in 1966, the United Nations called out the right of everyone to the enjoyment of the highest attainable standard of health in Article 12 of the International Covenant on Economic, Social, and Cultural Rights. Two obstacles, then, are defining population health and deciding that each person has a right to universal access to health. This is important because the right to health and the ability to affect with an E total population health will necessitate, as we've heard and know, a consideration of societal and environmental conditions as well as interventions. And this is important because the right to health care does not and will not equate to the right to health. Until and unless the right to health is accepted as an inalienable right, it will be more difficult than necessary to engage those other sectors. If they don't buy in, and it's only business and only the business imperative that brings us to the table, it is only the business imperative that brings us to the table. Those other sectors may wonder why they should engage, and I just ask you to think how hard it was to get to universal access for health care. We've got an intention challenge. Do we want to do population health? In addition to a societal norm about the right to health, financing population health policies and programs is an additional obstacle. While medical care expenditures continue to rise, governmental public health has sustained funding reductions at the federal, state, and local levels, despite analysis that suggests that investments in public health result in decreased mortality from cardiovascular disease, influenza, and other things, as well as improved status related to obesity. These funding cuts have not gotten the attention or the outcry from the general public, the healthcare sector, or from the business community that education-related funding cuts have gotten. And I'm not trying to compare the two. I'm just saying we haven't heard much, and in the education world, we've heard lots about the cuts, appropriately so. We have not heard a commensurate outcry about the cuts in public health. To put things in context, the CDC budget for 2012, Andrew, tell me if I'm in the right range, was in the range of $11.5 billion. Which represents 1.5% of the $765 billion in waste identified in the previously mentioned IOM workshop report. I worry that the triple aim that we all hear articulated, better care, better outcomes, lower costs, is discussed and too often thought about entirely in the realm of the medical care system. One final obstacle is that we don't think of ours as a unified health system that includes public health, medical care, and other sectors or components, because what we have at best is a fragmented system with a well-defined medical care subsystem, and at worst, a completely uncoordinated, fragmented health non-system. And whether we're talking about linked information systems, fully mature patient-centered medical homes, or accountable health organizations, a unified health system is necessary to optimize the public's health. I'm going to try to quickly talk about 3 concrete examples that I think offer at least a story that says if we had the political will to scale up and scale out, we could begin making a difference, even in the turf and even in terms that are relevant and of interest to the medical care community. One is work done in Texas, Texas Tobacco Initiative, 4 counties, where with an investment of $3 per person per year in those 3 counties, a substantial reduction in the initiation of tobacco use and a substantial reduction in the use of tobacco was achieved. Some analysis suggested that a statewide investment of $70 million annually could over 5 years result in a $1.4 billion cost savings, $400 million in indirect costs, and a net $650 million direct medical care cost reduction. One would think in a fiscally conservative state, this kind of business case would have everyone's attention. The political will was not there to make a statewide investment for tobacco control. Second example, the coordinated approach to child health, which is one of many evidence-based coordinated school health programs that for about $10 per elementary school child per year has leveled off or reduced childhood obesity rates in some communities in Texas. In addition, this is a program, to some of the comments made by Dr. Teutsch, associated with better academic performance and better behavior in elementary schools. If indeed it is about getting our kids out of schools, a program like CATCH and or others would be a great program to do some things that have a win-win aspect to them. And then lastly, the National Diabetes Prevention Project has certified the YMCA and others as DPP certified programs in community-based and in community-integrated settings. Many of the 79 million persons in the United States with prediabetes could have the opportunity to enroll in an evidence-based diabetes prevention program that really doubles as a health promotion program. And analysis has demonstrated a modest return on investment. And modest return on investment, an important point to be made. Sometimes in the world that we're in around population health, it boils down to what is the ROI? And we don't always talk about ROI when it comes to cancer care, cardiac care, or any of the care after the fact. So I'm about to close. I have found that most agree that it is generally better to be alive than the alternative, that it is generally better to be healthy than the alternative, and that it is generally better to prevent disease than to treat disease. And I'm convinced that altering the health cost trajectory in our country will require improvement of the public's health and a corresponding decrease in the burden of preventable and delayable diseases, and therefore a decrease in the demand for medical care. This will take a societal adoption of the notion of the right to health and a new commitment, the political will, to fund those things most likely to promote and improve health status. A newly conceptualized health system and a redirection of shared savings from re-engineered medical care with better information technology use, data analysis, primary care-based medical care, and accountable care organizations to what I have coined, and I think others are using similar variations of, to accountable health organizations that value health rather than care may be the way to appropriately resource efforts to achieve total population health. Thank you.
Well, thank you. Thank you so much, Eduardo. I'd like to jump in right now, but I'm not going to. We're going to move along. And our next speaker is David Williams. If you come on up here, David. David is the Florence and Laura Norman Professor of Public Health at the Harvard School of Public Health, Professor of African American Studies, and in the Sociology Department. He has published more than 230 articles in leading scholarly journals, I think really internationally recognized as one of the leading social scientists focusing on the social influences on health and on health disparities. And we had to begin this day here thinking about our work with that kind of emphasis, and I'm so glad that my friend David Williams came down to share his thoughts with us.
Thank you, Dave.